Hey there, Vanderbilt. Today we're going to talk about cytoreductive surgery and HIPEC. And I am so pleased to have Dr. Deepa Magge here with me today to talk about it. Welcome.
Thank you. Thank you so much for having me.
So great to have you. Please just tell me a little bit about your role at the Cancer Center.
Sure. I'm an assistant professor of surgery here at Vanderbilt. My primary role is to lead the peritoneal disease surgery group and the HIPEC program here at Vanderbilt.
Wonderful. Let's start with just describing what the HIPEC procedure is.
Sure. So the goal of cytoreductive surgery and HIPEC is really to remove the disease or debulk disease that we can see and feel in the setting of peritoneal carcinomatosis that ranges from diseases like appendiceal cancer all the way to colorectal cancer. So we do a cytoreductive surgery component of the case where we remove all of the gross disease, and then we perform a perfusion or a 90-minute period of time where we do a hot chemotherapy bath. That's the HIPEC portion of the case. So all in all, the procedure is a combined surgery. It all happens at the same time. It's just we break it up into two components.
Wonderful. Can you talk a little bit more about what the hot chemotherapy bath looks like?
Yeah, absolutely. So essentially, we place an inflow cannula as well as an outflow cannula into the abdomen when after we have explored the abdomen. And then we hook those up to a bypass machine, similar to what we use for our cardiac bypass. What we do is we heat up a chemotherapy agent. We primarily use an agent called mitomycin C. We heat it up, and then we introduce it into the abdomen through the inflow cannula, and it essentially is a 90-minute perfusion cycle. So you get the inflow of the heated chemotherapy, and then it comes out through the outflow cannula, and it's a continuous cycle for a 90-minute period.
Wow, that's fascinating. Who are the ideal candidates for something like this?
So I think what we say for this procedure is we offer it to patients who have peritoneal disease of different primary malignancies. So when I see a patient with appendiceal cancer, appendiceal cancers or tumors can range all the way from benign or somewhat benign mucinous neoplasms of the appendix to high-grade adenocarcinomas. We also use this procedure for colorectal cancers, ranging from low grade to high grade. But what sets a good candidate apart from a bad candidate really is the biology of the disease as well as the tumor burden. So when I see a patient, I think the first thing I determine is what is their biology of disease. So low grade mucinous neoplasms of the appendix have great prognoses after this procedure. However, high-grade tumors of the appendix or of the colon and rectum tend to respond well to chemotherapy because they're mutating and the cells are dividing very rapidly. So we tend to do chemotherapy for those patients up front rather than this procedure up front. The low-grade processes tend to behave better and respond better to this treatment modality. The other issue is the tumor burden. We calculate a PCI, which is a peritoneal carcinomatosis index, which essentially is a value we give to the extent of the disease in the abdomen. And we determine that based on a combination of using CT imaging as well as diagnostic laparoscopy, which is where we do a camera surgery to assess the involvement of the different quadrants of the abdomen. Patients with lower PCIs or lower tumor burdens also do much better than patients with more extensive disease.
Wonderful. So those are a lot of the factors that you determine the benefit of the treatment from. Are there any other factors?
So I think for the higher grade processes or the moderate grade processes, which are in the middle, I also use response to chemotherapy as a marker of their biology of disease. So if a patient has high grade disease that is not responsive to chemotherapy, what I feel is that biology is very aggressive. So if they are not responding to systemic chemotherapy, then the cytoreductive surgery and HIPEC will likely not have much benefit for those patients. So if they have a really good response to chemotherapy, that tells me that their biology may be less aggressive, and even though it's high-grade disease, they may be a candidate for the surgery.
Okay, wonderful. Why is this typically only offered at major medical centers like Vanderbilt Medical Center?
So I think two things go into that. I think it's a highly technical procedure. I think it requires specialized training to be able to do those surgeries, and it's usually provided by fellowship-trained surgeons who many times practice in large academic centers. I think the other side of the coin is also the surgery has its complications, and I think recognizing those complications relatively early postoperatively is really important in management of patients. And I think with in a larger academic centers, you have more specialized nursing care, you have residents and fellows that are able to recognize these complications much earlier and able to manage these patients much better. So I think it goes from both sides of the coin, both the surgical training and the extensiveness of the surgery, as well as the postoperative care that's offered at a larger academic center. I also think what's important is determining what patients we should do this operation on, and I think that's an important skill that's learned with more practice and doing more operations, and patient selection really is key here. And I think surgeons at academic centers who are doing more and having higher volume, they have a better recognition of what patients should be undergoing this procedure. And I think that's why patients should come to academic centers to have this surgery done.
Wonderful. And I know we have a wonderful team at Vanderbilt that I know it takes all hands on deck with a surgery like this. So
100%. I think the nursing care is optimal here. They know how to take care of these patients. Even intraoperative care is fantastic here. And I think we have a wonderful team here that's able to do these procedures.
Wonderful. Why did you personally get interested in this treatment modality?
That's a great question. So, you know, my job as a surgical oncologist is really to offer hope to patients. And I think one of the hardest things is saying that we can't do anything for somebody. And when I was a resident and fellow at UPMC in Pittsburgh, one of my mentors who is a pioneer in HIPEC, his name is Dave Bartlett, he showed me that you can really offer hope to patients that prior to this operation, we're basically told that we're going to do palliative therapy for you. And even for the low-grade processes, a lot of patients were being told there's nothing I can do for you. Chemotherapy probably won't help you, but there's nothing I can do for you surgically. And I think our role as a surgical oncologist really is to help patients and to be able to provide that hope. And I think this field, peritoneal disease in particular, is of interest to me because I feel like I can offer hope to those who maybe didn't have any before. And I think that it's a really interesting field. I think there's a lot of new data that's coming out. Even though it's been around, the surgery has been around for decades. I think there's a lot of new research that's being done and a lot of new innovative techniques that are being used. A lot of new studies that are being done worldwide, including some new clinical studies. And so I think it's, even though it's not necessarily novel, I think there's a lot of new data coming out, and I think that's exciting to be involved in an evolving process.
Absolutely. Surgical oncology is such a fascinating field, and it's really given a lot of hope to people that didn't think they had any. So this procedure has interested me since I've learned about it from your colleagues as well. So I just want to thank you so much for talking to us about this. It's just been a pleasure getting to know you since you came to Vanderbilt, and we hope to do this again soon. Thank you so very much.
Thank you.
Once again, this is Dr. Magge, and we have had a great time talking to you today. Thank you so much.
Thank you so much. I really appreciate the opportunity to do this with you.
Absolutely.